egg here has to move across the vein wall, across tissues, to then exit the body in either urine or feces, based on whether you have urinary schisto or intestinal schisto. Once the egg gets into fresh water, it will hatch, and this little thing will come out of it and swim around. It's called a Psidium. It will invade a snail. Inside of the snail, it will proliferate, and what you see coming out of this snail are a number of little dots, which we call cercaria. They look something like this, if you can see it. And those burrow into the skin of the next person when they go swimming or when they're in the water and cause the infection. Here is a urine microscopic examination of a kid in Mali who has a very, very heavy urinary schistosomiasis infection. And here are a bunch of kids in Nigeria, all showing little vials containing their urine, which is very bloody as a result of these eggs coming out in their bladder. As they come out, they cause bleeding. There are a lot of organ damage that occurs from these eggs, because not all come out. Some stay in the tissues, like in the bladder, in the kidneys in the case of urinary schistosomiasis, in the intestine and in the liver and spleen in the case of intestinal schistosomiasis, and this causes a lot of issues and a lot of problems and a lot of chronic disease. This child has a very large abdomen because of his large liver and spleen resulting from schistosomiasis. Water contact, everyday activities of washing, kids swimming, because kids in the tropics spend a lot of time in the water. Kids tend to be most heavily infected with schisto. And here is a big tin of the medicine Praziquantel. A third medicine, I've told you about ivermectin, mectizan, I've told you about albendazole. The third one is Praziquantel, and this one is being used to treat this kid. The important thing about Praziquantel is it is a medicine that has not been donated. So we have to find money to provide treatment for schisto, at least up to recently. It's a child taking her dose of Praziquantel. Recommended to take the medicine once per year, just like the other ones. We're really talking about annual doses of these medicines to prevent these conditions. So, onchocerciasis is control, lymphatic filariasis is elimination, schistosomiasis, control. Control programs, you have to dose people pretty much from now to eternity. The lymphatic filariasis program is aiming to eliminate, so at some point we can stop treating. Okay, that's my background on the three diseases. Now let's journey to Nigeria and talk a bit about the Nigerian programs. In case you don't know where Nigeria is, here's Africa, there's Nigeria, West Africa, and here's the capital, Abuja, and we're talking about work that's going around the city of Jos, on the central plateau in the country. I've worked in Nigeria since 1992, had great experiences in Nigeria. People always hear Nigeria and get freaked out, but actually in my time there it's been very, very profitable, great people, great opportunities, and lots of parasitic diseases. Here's central Nigeria, where our integrated program is ongoing. And so now let's go into talking a little bit about bundling. Talked about the neglected diseases. I'm going to talk about bundling of treatment services. Why Nigeria? Nigeria has the most river blindness in the world, 27 million people in need of treatment. And it also has the best mectizan distribution program for river blindness in the world. A perfect thing, a perfect logistical system to start bringing these other conditions in on top of, because you already have a system that's functioning to integrate with. Nigeria has the most lymphatic filariasis in Africa. 22% of Nigerians are infected with this parasite. Nigeria is third globally after India and Indonesia for this condition. And for schistosomiasis, Nigeria has the greatest Praziquantel tablet need of any country in the world, including China. So Nigeria has a lot of parasites, and it also has a lot of other diseases like intestinal worms and trachoma and malaria. As a matter of fact, with malaria, more children, 1 million children are estimated to die a year of malaria, and 300,000 of those are Nigerian. More Nigerian children die a year of malaria than any other nationality. Here I am in northern Nigeria outside of the Emir's palace with people in their traditional dress. Now, we published this work back in 2002 and have continued to build on the notion of lymphatic filariasis elimination, schistosomiasis control in combination with onchocerciasis control. So, river blindness, lymphatic filariasis, and schistosomiasis through mass drug administration. Here's a picture of Dr. Abel Agege, who is the director of the activities in Plateau and Nasarawa states. And this is how we integrated these three mass drug administration programs at the district, or what we call local government area. First, we built on the river blindness drug administration platform. First, we had to determine what the conditions were that warranted treatment. In other words, we had to do something called mapping. We had to do epidemiological mapping in accord with guidelines of the World Health Organization to determine where the medicines needed to be given. We then tailored our distribution training and logistics based on the results of these mapping exercises. And we implemented community-based treatment and health education where it was appropriate, again per guidelines, and we evaluated the impact. So the concept here in mapping and spatial epidemiology is that you start off with one platform. Based on the epi, you build on another disease and even more focal activities across what you find in your disease assessment activities, frequently using geographic information systems to help us sort these things out. So when we started in 1998, our disease mapping for river blindness in these two states gave us this kind of picture. Each one of these little segments is a local government area, this is equivalent of a county, and these areas required treatment for river blindness, or onco, and these areas did not, based on the WHO threshold of having 20% of people in communities having nodules or not. If you're above 20%, you get mass treatment. If you don't get mass treatment. This graphic shows the impact between 1992, when we started the program, of 51% prevalence in these areas, dropping to 2.9% by the year 2000 due to the impact of the medicine and the treatment. Now, you might have trouble making some of this out, but I just want you to take a look at this mapping exercise for lymphatic filariasis in the same area, which we conducted around the year 1999. And the point is that the threshold for mass treatment for lymphatic filariasis is 1%. 1% of infection using a rapid diagnostic test. And you can see, just looking next to these names of villages, that all of these numbers are over 1%. As a matter of fact, there's only 1 0 here in this entire map, which basically told us that unlike onco, we had to treat statewide in all of the 30 local government areas for lymphatic filariasis, and the program had to expand. So the map looks like this now, after the mapping. These areas are both onco and LF, and these areas are LF alone. And this is how it looked. We started off with mass treatment in 1992, treating about 500,000 people per year. In 2000, we launched the program in a few local government areas to add albendazole for lymphatic filariasis in combination treatment. Now you're hitting two diseases. We grew to the entire onco area by 2001 and then expanded up to 3 million treatments per year to reach everyone for lymphatic filariasis in those other districts by the year 2003. And what happened was we moved from an onco platform to now a much broader, by the year 2003, lymphatic filariasis platform. And LF became our platform program with which to hang other activities. This is just a graphic which shows how our treatments looked through 2007, combined LF and onco treatments with ivermectin and albendazole, about 3.5 million people being treated per year. And that was really pretty easy. The integration of lymphatic filariasis with river blindness was fast and easy. And what we're trying to do, however, is to eliminate lymphatic filariasis.